Hello again. This is the third and most probably the last part of the mid-semester 2 revision video. And we will start by talking about the microbiome in your nasal cavity. Of course, just like any other cavity in the human body, it provides shelter because it's relatively warmer, it's relatively darker, and also provides nutrition because there are mucus discharged in the nasal cavity, and mucus is a protein, as you know. So it contains friendly flora. What is the commonest friendly flora present in the nasal cavity microbiome? It is Staphylococcus aureus, and you can see it in the picture. It's spherical, it's grape-like, and under the colored electron microscope, or the scanning electron microscope, we can see it golden in color. That's why it is called Staphylococcus aureus. Okay? Of course, Staphylococcus can turn pathogenic into certain individuals, but in general, some people, not all people, harbor or have Staphylococcus aureus in their nasal cavity and do not show any symptoms. So the question here, what are nasal carriers? Nasal carriers are individuals who harbor the friendly flora, Staphylococcus aureus, in their nasal cavity and do not show any symptoms, okay? And then that's why we call them carriers. Nasal carriers, they carry the microbe in their nasal cavity, and they're just carriers. They are not diseased, they are not patients because they do not show any symptoms. But Staphylococcus aureus is a potential pathogen, and this is the next question. What do we mean by a potential pathogen? A potential pathogen is a friendly flora that can turn pathogenic under certain conditions. Certain conditions like what? Like decreased immunity of the host taking or receiving chemotherapy or receiving radiotherapy. So this is the second question on the slide. What is a potential pathogen? The third question is, why do nasal carriers represent a risk to people around them? They represent a risk to the community. Number one, because they are not known. You can never know whether a person is a carrier of Staphylococcus aureus or not. Number two, because even if they are asymptomatic and do not show any symptoms, they can cough or sneeze and transmit the microbe to another person who might get infected by Staphylococcus aureus, having lower immunity. So they represent a source of infection to people around them, although they do not show symptoms themselves. That's why they represent a risk. They are more risky than people who are obviously diseased, because if a person is obviously diseased, you will keep a distance and you will not approach. The third risk of the nasal carriers is that they can infect themselves, meaning that they have Staphylococcus aureus in their nose as a friendly flora. But when they cough or sneeze, droplets of their saliva or droplets of their nasal discharge or droplets of sputum from the bronchi can be carried by air and fall onto their own skin. If the skin is completely intact, then Staphylococcus aureus will stay friendly. But if the skin is abraded, even a slight abrasion or a very superficial wound, then Staphylococcus aureus will turn pathogenic and will invade the skin and will cause a self-infection. Why is it called a self-infection affecting the skin? Why is it called a self-infection? It is called a self-infection because the asymptomatic carrier is infecting itself with its own microbes he is or they are harboring in their nasal cavity. Why it is called auto-inoculation? Auto means self. Inoculation means injection because it is as if you were injecting your microbe into your own skin. Again, how do nasal carriers spread infection? They spread nasal infection by droplet infection. And now we have to define droplet infection. So what is droplet infection? Of course, droplet infection is a method of transmission of infection. And it is a method of transmission of infection by infected droplets. So it is a way or a method of transmission of infection by droplets. Droplets of what? Small droplets of what? Small droplets of nasal discharge if the patient coughs, sputum, again, if the patient coughs, or saliva if the patient sneezes. Okay, so this is simply droplet infection. When the patient coughs, when the patient sneezes, droplets, small droplets of saliva and nasal discharge are released from the nasal cavity and from the mouth cavity and can infect others. These infectious droplets can infect others, okay? But how are droplet infections transported to the other person? We have already agreed that it is called droplet infection, but how is droplet infection transported to the other person that receives it or that receives who receives the droplets? We have three ways. The first one is air droplet infection or airborne droplet infection, in which the droplets of saliva, the infectious droplets, are carried by air and then inhaled by the person. So the closer the person, the more the liability of infection. The second possibility is dust-borne infection, letter B. Dust-borne infection means that you do not have a person close to you. You just cough or sneeze carelessly, and the droplets fall onto the ground. They fall onto dust in particular. And then at the beginning, they're wet, and the dust is heavy. But when they dry out by the effect of the sun rays and the heat, then they become lighter, and the infected or infectious, they are infected and they're potentially infectious at the same time. The infected and infectious dust particles will be carried by air to be inhaled by somebody else. So on a windy day, on a dusty day, the possibility of dust-borne infection increases. The third possibility is foodborne infection, meaning that you might have a plate, for example, on a table, and then you're passing by, you sneeze or cough carelessly, and droplets of your saliva fall onto the content of the dish, and the person who comes later does not know that all this happened and will eat the food happily and get the infection in his body. The second way nasal carriers spread infection is by direct contact. In order for the method of transmission of infection to be called direct contact, there should be a direct contact between the source of infection and the other person. So, for example, if a nasal carrier, like some people in rural areas do, or some non-educated persons can blow their nose with their hands, and this is extremely disgusting and extremely dangerous to the community because they now have dried out nasal discharge on their hand. When you shake hands with that person, you do not see the dried out discharge. So infection is transmitted to you by direct contact, by shaking hands with him or with them. The second thing is that they might, with their contact, so the common factor in all three examples of direct contact is contaminated hands and, of course, direct contact. If you have contaminated hands in the way we said, and you touch fomites, any solid object that can transmit infection, like magazines in a clinic, for example, or the chairs in the clinics or in the reception of a hospital or a school or whatever, then any person who comes later and touches the same object will get the infection. And the third and last example, that you did not only sneeze or cough on the food, but you, for example, you took a bite from the food and then you give that food that you have bitten to your friend, and the friend puts his mouth at the same place and the infection reaches him. So it might be an animal or it might be a human body. And now we move on to the conjunctiva. And as you know, the conjunctiva, we cannot see the conjunctiva. The conjunctiva is a thin, transparent tissue that covers the sclera of the eye and coats or lines the eyelids from inside, and it starts at the periphery of the cornea, meaning that it does not cover the cornea. So what is the conjunctiva? A thin, transparent tissue that covers the sclera of the eye, the white of the eye, and coats the upper and lower eyelids from inside. And this is a lateral view of the conjunctiva to see how it is folded in order to cover the sclera and to coat the eyelids from inside, and that the conjunctiva, which appears here red, although it's transparent, it's just highlighted, does not cover the sclera. Okay, and here we can see the lacrimal glands, and here we have a justified question: why do we have a runny nose when we cry? Because when the lacrimal glands secrete a lot of tears, more than the capacity of the nasal duct to carry the tears to the nose, then we will have tears coming out from the eye, and those tears are carried by the lacrimal sac to the nose, and the nose becomes runny because of the tears, in addition, of course, to the congestion congestion of the nose that occurs during crying. The conjunctiva is highly protected. It's not every day that you find a person around you or in the clinic with a conjunctival infection, unless we're talking about a rural area with very low hygienic measures. How is the conjunctiva protected? As usual, by its structure and by its function. And it is protected, as usual, mechanically and chemically. So mechanically, this is because we have the thin film of tears, which we call the liquifilm, the thin layer of liquids that covers the eye. Is it enough to say this? No. We have to say that this liquifilm traps dust and bacteria. And is it enough to mention these two items only? No, we have to say that blinking at the end of the day will wash away the liquifilm with the trapped dust and microbes, and then a new liquifilm is produced. Of course, here we have a related justify question or justification question, which is when people have dry eyes, for example, because of an autoimmune disease, they get frequently infected in their eyes. Why? Because having dry eyes means that they lost their mechanical barrier, they lost their liquifilm. And then the eye has a chemical barrier through the tears themselves, because the tears contain an enzyme called lysozyme enzyme, and that lysozyme enzyme, as you see on the slide, can break down or digest the bacterial cell wall. So we have a mechanical protection and a chemical protection. Of course, I sometimes get only the mechanical barrier, discuss the mechanical protection of the eye, or discuss the chemical protection of the eye, or I might ask generally discuss how or the mechanisms that protect the eye against infection, or a fourth way I can ask the question is describe the role of the tears in protection of the eye. If I say describe the role of the tears in protection of the eye, I'll not tell you, please mention the mechanical barrier and mention the chemical barrier. It's up to you to remember this and mention it. There is a fifth question that is related to that slide, which is, if it happens that a microbe infects the conjunctiva, then what are the characteristics of that microbe? This would be a very straightforward question. I might say, for example, some organisms succeed in infecting the conjunctiva. Justified. Why specially? Why those microorganisms in particular are capable of infecting the eye, whereas the rest are not? This is because they can overcome the barriers that protect the eye. They can overcome the mechanical barrier. They are not washed away. They attach strongly to the conjunctiva. This is one point. And they can resist, they can also resist the chemical barrier by resisting lysozyme. As you know, when the newborn is being born and passes through the vagina, there are plenty of of bacterial flora in the vagina that might infect the eye, and that's why it is a routine to instill eye drops, antibiotic eye drops or bactericidal eye drops in the eye of the newborn, and this also can be a justified question. In concerning flora in the urinary tract, of course there are flora, but they are very, very few. Why? Because the medium of the urinary tract is not suitable for continuous living or for being a habitat for bacteria because of two reasons. They're also considered barriers. We have a mechanical barrier, which is the downward flush of urine, starting from the kidney, down the ureter, the urinary bladder, and then the urethra. Urine is being flushed downwards by the effect of gravity, by the effect of peristalsis. This continuous current or flow of urine washes away any microbe and does not allow the long residence of any microbe in the urinary tract. And the second factor is a chemical factor, because urine is highly acidic, or not highly, but slightly acidic, and the pH of urine is 5.6. We can say it is acidic, and this acidity is not affordable by many bacteria. Only very few bacteria can withstand that acidity, and we call them acidophilic bacteria or acid-tolerant bacteria. Another question that is related to the urinary tract infection is, why do we call the infection that occurs in the urethra an ascending infection? Ascending infection meaning that the microbe is ascending upward against gravity. Yes, if it happens that a microbe resists acidity and resists the mechanical downward flush and succeeds in infecting the urethra, this will always be, or not always, but mostly be, or more commonly be, an ascending infection, meaning that the microbe comes from the skin around the urethra and then ascends upwards along the urethra. Of course, the famous vaginal microbiome and the famous question about the vaginal microbiome. But I might ask you preliminary questions like, before puberty, does the microbiome, does the vagina of the newborn, the vagina of the newborn contain bacteria? Yes. After 2 or 3 days, the vagina of the newborn will contain bacteria from the surrounding skin, from the air, and it will contain a few friendly flora. And amongst these few friendly flora, there is the lactobacillus coming from the skin around the opening of the vagina. So the most famous friendly flora in the vaginal microbiome is what? It is lactobacillus. Right. Lactobacillus breaks down the glycogen stores that are present in the muscles of the wall of the uterus and the vagina, but mainly in the vagina. And it converts glycogen first into glucose and then into lactic acid in an anaerobic process of fermentation, acidic fermentation. So there are lactobacilli in the vagina before puberty. There is glycogen in the muscular wall of the vagina. There is a certain amount of lactic acid that is produced, but only very, very little lactic acid is produced. This lactic acid, I might ask you, what is the importance of lactic acid in the vagina? The importance of lactic acid in the vagina is to protect against fungal infection. What happens at puberty is that protection increases because exposure to microbes increases. So what happens is an estrogen surge, increased glycogen stores in the vaginal walls, increased breakdown of glycogen by lactobacilli into lactic acid, and therefore increased acidity of the vagina. I might ask you about the acidity of the vagina. Is the acidity of the vagina good or bad? The acidity of the vagina is actually usually good because it protects against fungal infection like Candida albicans infection. But it is sometimes harmful because it kills the sperms and therefore results in infertility of the female. As we said before, the oral cavity is an excellent habitat for bacteria, being warm, being dark, containing food debris, epithelial debris, and mucus. And in exchange, of course, the oral flora give us all the benefits that are given by friendly flora, like occupying space, like cross-reactivity, like microbial antagonism. The oral cavity microbiome comes mainly during breastfeeding from the skin of the nipple and the areola, but it might also come from the skin of the newborn itself around the lips. Oral flora examples, of course, include lactobacillus, which is the most famous, P. acnes coming from the skin, staphylococcus coming from the skin, and streptococcus. The most injurious is streptococcus because if streptococcus decides to be pathogenic, it will cause severe sore throat. The oral flora benefits, we have mentioned them several times. They occupy space, so they prevent intruders. They give vitamins and organic acids. Vitamins are nutritious and organic acids kill pathogens. And then we have the cross-reactivity. They have weak antigens, the friendly flora. They stimulate the immune system. The immune system produces cross-antibodies and cross-react with other pathogens that have the same antigen as the friendly flora. In microbial antagonism, this is direct because in cross-reactivity, it is an indirect or an indirect mechanism where the friendly flora does killing of the pathogen through the immune system. But in microbial antagonism, there is no recruitment of the immune system. There is no stimulation of the immune system. So if we compare between them, the main difference is that cross-reactivity is indirect, whereas microbial antagonism is direct. Cross-reactivity involves the immune system, but microbial antagonism does not. In cross-reactivity, it is the immune cell that kills the pathogen, but in microbial antagonism, it is the friendly flora that kills the pathogen directly. I might ask you, how do friendly flora kill microbes or pathogens? By secreting bactericidal substances. What is a bactericidal substance in general? It is a substance that is capable of killing bacteria, okay? What are examples of bactericidal substances? Examples include peroxides, organic acids or fatty acids, and bacteriocins. What are bacteriocins? Bacteriocins are a subtype of bactericidal substance. Bacteriocins are protein in nature, but they're not useful proteins. They are toxic proteins because they will kill or inhibit the growth of pathogens, but not any pathogen. Again, pathogens that are closely related to the friendly flora. So this is almost the only similarity between cross-reactivity and microbial antagonism, that in order for the friendly flora to kill the pathogen, either directly or indirectly, there should be similarity in structure between the two. But there are harms, and the main harms are dental caries and gingivitis and all the stages of periodontitis. First of all, what is the gingiva? The informal name for gingiva is the gum. So it is the pale pink tissue that surrounds the teeth and covers the jaw bones. Why is it pink in color? Because there are numerous underlying blood capillaries that give it the pink color. Is the gingiva a living tissue? Yes, the gingiva is a living tissue because it contains blood vessels and nerves. What parts of the tooth does the gingiva cover? It covers the neck and the root of the tooth if we don't have inflammation. But the gingiva can be affected by the friendly flora that turn pathogenic, in which case we will have gingivitis. What is gingivitis? It is inflammation of the gingiva. What are the signs of gingivitis? The signs will be the same as the signs of inflammation: red gums, swollen, painful, and warmer than normal. What is the source of gingivitis? It is plaque. but plaque is on the teeth, not on the gums. What is plaque? Plaque is a biofilm. What is a biofilm? It is a thin layer of living organisms with some moisture or some water and some food debris. The plaque settles on the surroundings or the periphery of the tooth, and it builds up. It builds up from food remains if you neglect your oral hygiene, from proteins and mucus in saliva, and that accumulates every day. And we will see that if you neglect plaque, there will be harmful effects. What are the main harms of plaque if you neglect it? First of all, there will be tooth cavities. And I might ask you to list the harms of plaque. So you would say tooth cavities, gingivitis, calculus, gum retraction, and bleeding gums. List means just enumerate or mention the names. But I might take every point and ask you about the correlation between that sign or that point and plaque. So what is the relation between plaque that you see here on the teeth and tooth cavity? Plaque contains bacteria. Bacteria work on food remains and break them down. Breaking them down will produce lactic acid, and lactic acid will produce holes in the enamel of the teeth called dental caries, because it dissolves the acid, lactic acid dissolves calcium in the teeth. So caries is always on the tooth itself, not on the gums. But the origin is plaque. What's the relation between plaque and gingivitis? It all starts with bacteria again. Plaque contains bacteria, and bacteria cause inflammation of the gums and gingivitis. There are toxins released, there is a histamine release, there is vasodilatation, and the gums become swollen, red, painful, and warm. What's the relation between plaque and the third complication, which is calculus? Of course, if you ignore plaque or if you neglect cleaning up your plaque or removing it, then saliva contains calcium salts and phosphate salts, and these will precipitate on plaque. So plaque will be converted from, or will change from a soft biofilm called plaque into a calcified hard biofilm called calculus. Plaque is lighter than calculus. Plaque is usually yellowish white, yellowish white, but calculus is usually brownish or yellowish brown. So it is much darker, it is harder, it is calcified because of the calcium salts in saliva. So see the paradox, the contrast. In dental caries, the acid is dissolving calcium, is removing calcium from the enamel of the teeth, whereas in formation of plaque, in the formation of calculus or tartar, there is deposition of calcium salts. Where did they come from? They came from saliva. And then letter D, we have gum retraction. What's the relation between plaque and gum retraction? It is essentially that plaque contains bacteria again. Bacteria causes inflammation of the bones, so the density of the bone will diminish. There will be bone weakness and destruction, or weakening and destruction, and therefore the gums, although they are inflamed, they will retract. They will be shrunken because of the shrinking of the bone underneath them. And then finally, the bleeding gums. Of course, if I have gingivitis and I have a red, swollen, painful, gums, they're red because there is more blood flow to the gums. So they easily bleed upon brushing. And here you have a comparison. We have said that on the previous slide between plaque and calculus. Calculus is also porous, meaning that when the calcium deposits on plaque, converting it into calculus, it does not deposit in a regular way, and there would be every now and then, there would be like pores inside the calculus. Of course, you have to know the characteristics of healthy gums, and I'm sure you all know them. They are not red, they are pale pink, they are not swollen, they are not retracted. There are no pockets, the neck and the tooth are not visible, there is no bleeding, and so on. And then the functions. The function is something other than or different from the description. If I say define or describe the gums, you say it's a pale pink tissue that covers the jaw bones. But if I say the functions, they should be functions, meaning that being pink is not a function. Covering the gums is not a real function. It's covering the bones, sorry, because it's just by being there that it covers the bones. But the main functions of the gums is that they contain, or the gums contain blood vessels to nourish the teeth, provide oxygen and glucose, and take away waste. And taking away waste is as important as providing oxygen and nutrients, because accumulation of waste might lead to death of the living tissue inside the tooth. It contains nerves for sensing the pain or detecting the pain, and it provides mechanical support to the tooth. Now, periodontal diseases are diseases affecting the tissues around the tooth in general, not the tooth itself, but the tissues around the tooth. So periodontal diseases, in other words, are diseases that affect the gums or the gingiva and the underlying bones. So periodontal diseases are usually infectious diseases. So it is infection of the gums and the underlying bones. There are 3 stages for periodontal diseases. The early stage, which is gingivitis, it's just that the gums are swollen and red, and of course on the teeth you will find plaque. The second stage, which includes intermediate and advanced periodontitis, as we said in class, and here you will find that the bones will start shrinking, the gums will start shrinking, the tooth will apparently look longer, and the neck and the roots start to be apparent, and the tooth becomes more and more loose to the extent that it might fall out at the end of the day. Now here we can see the stages of periodontitis. Of course, you have to know them par cœur, as we say in French, meaning that here you have healthy gums. They are pink, they are not swollen, they are not red, there are no spaces in between. They are not shrunken, and the teeth do not have any plaque or calculus on them. Here we start seeing plaque, and then we start seeing, here this is early periodontitis, which is equal to gingivitis. You have plaque on the teeth, not on the gums. You have swollen, inflamed, painful, warm gums, but the bones hasn't yet been destroyed. In intermediate periodontitis and in advanced periodontitis, we have the same stages. We have the same characteristics, with one difference is that advanced periodontitis is more serious than intermediate periodontitis. So don't get mixed up, don't get confused. Gingivitis is early periodontitis. Here, this is intermediate or middle periodontitis, and here we have advanced periodontitis. In intermediate periodontitis, plaque is converted into calculus. It hardens and becomes porous and becomes darker and becomes more difficult to remove. The gums and the bones shrink more and retract more. So we start seeing spaces or pockets between the tooth and the gums, and spaces or pockets are a good medium for bacteria to thrive, and therefore the pockets have a very bad smell, usually because of bacteria and their waste products. In advanced periodontitis, everything becomes more exaggerated. The pockets become deeper, the tooth becomes looser, it separates more from the gums and the bones, which are more shrunken and more destroyed, and the tooth is about to fall. So you have to know this very well, the characteristics of every stage. And then we come to the tooth anatomy. Of course, there are plenty of questions here. Enamel, the outermost layer, is the hardest tissue in the body. It is highly calcified. It is a dead tissue. And that's why when you have dental caries in enamel, you do not feel any pain. I might ask you, dental caries or tooth cavities affecting enamel only are not painful. This is justified. This is because enamel is a dead tissue that does not contain nerves or blood vessels. Dentine is softer. Dentine contains less calcium salts, and therefore I might ask you to justify the spread of dental cavities occurs faster in dentine. This is because dentine is less calcified and is less soft. Is dentine living or dead? It is a living tissue because it contains few blood vessels and nerves. Like if you have dental caries reaching dentine, is it painful or not? It is painful, but not extremely painful. Why? Because dentine contains only a few nerves. The richest blood supply and the richest nerve supply and the truly living tissue is the innermost tissue, which is the pulp, which is present both in the crown above the gum line, and in the root below the gum line. Of course, there is a famous justification question. Dental caries or cavities affecting the pulp are extremely painful because the pulp is rich in nerves. What is the crown? The crown in general, with all its three layers, it is the part of the tooth above the gum line. What is the root? It is the part of the tooth below the gum line. Of course, the number of roots differs between teeth, premolars, and molars. Some molars have 4 roots. And then we have cementum. What is cementum? It is the extension of the enamel under the gum line, below the gum line. And we have here the periodontal membrane that is adherent to cementum. And what is the periodontal membrane? It is nothing but the extension of the gums below the gum line. Here we have the stages of dental caries. As I told you, here it's not painful, here it is slightly painful, and here it is extremely painful because it has reached the pulp. Here, dental caries spreads very slowly. Why? Because enamel is extremely hard. Here it spreads a little bit faster because it is less calcified, less hard. And here it spreads very rapidly because pulp is not calcified at all. Of course, the presence of food remains, especially sugar or sugars in general, is the main risk factor for having dental caries. And then we have the complications of dental procedure. We have studied only one complication, which is subacute bacterial endocarditis. What is subacute? It is a disease that is midway between acute and chronic concerning the onset, the course, and the severity of the symptoms. How does this happen? Explain the pathogenesis of subacute bacterial endocarditis in dental surgical procedures where there are wounds in the gingiva. Bacteria from the oral cavity, from the friendly flora, like streptococci in particular, might invade the bloodstream, causing bacteremia. What is bacteremia? It is the presence of bacteria in blood. What is the risk of bacteremia in such a case? Those bacteria will settle on diseased heart valves, will settle on the connective tissue in the knee joint, and will settle in the kidney and will settle in the blood vessels and cause all these symptoms you see of subacute bacterial endocarditis. The endocardium is the innermost layer of the heart. Why do we call it like this? Because the valves are an extension of the innermost connective tissue of the heart. The symptoms are a flu-like symptom, systemic. It's a systemic disease affecting the whole body. Joint pain on both sides, especially the knee joints, affection of the kidney leading to bloody urine or hematuria, and those longitudinal streaks under the nails, which are called splinter hemorrhages. Concerning the gut microbiome, of course, the most important questions are, first of all, the first question is the stomach a suitable place for living of bacteria? No. Why? Because the pH of the stomach is strongly acidic, 2.5, and only very few bacteria can withstand acidity. So I then might ask you, give examples of microbes that can withstand the gastric acidity, and you would say Lactobacillus, which is a friendly flora, and Helicobacter pylori. Of course, it is curved like a helix or twisted like a helix, and it lives in the pylorus of the stomach in the lowermost part, and it causes 3 categories of diseases or 3 levels of severity. The first one is just gastritis, inflammation in the stomach, and it causes nausea, persistent vomiting, frequent burping, bloating, diarrhea, weight loss, and so on. But the second more severe disease is ulcer. And I frequently ask you, what is the relation between H. pylori, Helicobacter pylori, and gastric ulcers? First of all, what is an ulcer? Let me remind you of this. It is a wound or a discontinuity in the gastric mucosa. How can Helicobacter cause this? Because Helicobacter is a pathogen. It secretes harmful toxins, and these toxins kill or prevent the reproduction of the mucus-secreting cells in the wall of the stomach, in the gastric mucosa. These mucus-secreting cells are called goblet cells. When these mucus-secreting cells lining the stomach are destroyed, they can no more secrete mucus. So there is no more mucus to coat the stomach from inside and prevent the effect of HCl. In such a case, HCl and pepsin enzyme will perforate or will dwell into the wall of the stomach and cause an ulcer. The third greatest level of severity is cancer for the same reason. The disease is a chronic disease. It is a recurrent disease. And if it is recurrent, the chronic inflammation will result in uncontrollable, unwise, mad reproduction, very rapid reproduction of the cells, and resulting in a cancerous mass inside the stomach. How can we get, it's important to know how we can get the infection. We can get the infection from polluted food or polluted water, and the food and the water are polluted mainly by feces or by the contaminated hands of the patients. Of course, it can be treated by antibiotics and antacids for the vomiting and the excessive acidity. Actually, not for the excessive acidity. We give antibiotics to kill H. pylori, but we give the antacid because if the patient has gastric ulcer, the presence of acid in the stomach will exaggerate the symptoms. So we give antacids to diminish acid production and therefore diminish the pain of gastric ulceration. The last thing we will be discussing is the friendly flora bifidobacteria. As we said before, bifidobacteria is first introduced into the gut, which is the final destination. If I ever ask you what's the final destination of bifidobacteria, it is the gut. It is first introduced into the gut through breastfeeding, and this is one of the benefits of breastfeeding. Bifidobacteria come from the skin on the areola and the nipple and the skin of the breast of the mom, and upon suckling, bifidobacteria are introduced into the colon. They pass through the stomach and they are not affected, and they reach the colon. So they are introduced into the colon, and bifidobacteria are the predominant bacteria in the gut. So I might ask you about the cause for this. Justify 90% of the colonic bacteria are bifidobacteria in breastfed infants. This is because the breast milk contains a growth factor that helps reproduction of the bifidobacteria. But just like we have useful bacteria in the gut, we also have the bacteroids, which are very toxic, which produce toxic products. And these toxic products can, toxic products of their metabolism can cause cancer colon. You have to know the shapes of the bacteria very well, because I might get you the picture and ask you questions without mentioning the name of the organism. So you must know the shape of Helicobacter and the shape of bifidobacteria. You can select some of these benefits of bifidobacteria and memorize them. They're immunomodulators. They absorb procarcinogens. Of course, they inhibit growth of pathogens. They improve mineral absorption like calcium, magnesium, iron, zinc absorption. They reduce any liver toxins coming with the bile and prevent their absorption. They produce vitamin B. They diminish food allergies, they lower cholesterol levels in the blood, they secrete chemicals that prevent absorption, and of course, they are taking over, and therefore they help or reflourishing or restoring the gut flora. Okay, that's it. But before leaving you, I'll be mentioning or remind you again that you will have a diagram on a longitudinal section of the tooth with all the labeling, and it is out of 6 marks. And you have to have your colors, because if you don't color, you will be losing marks. And the second question is about the dialogue, and the dialogue is an interview between you and the microbiome. So if I said something different in the class between bacteria, pathogens, and friendly flora, no, it is you are the interviewer. You will be the interviewer, and you will be interviewing flora in the gut. I don't remember if you're interviewing only friendly or pathogenic. You have to read the question well. And you will be asking those flora about their habitat, for example, where they live, how do they feed, what do they give the human body in exchange? Do they always live in peace in the human body, or are they sometimes exposed to dangers like diseases or immunocompromisation from the part of the host, or like pathogens intruding themselves? And how do they behave or react in such a case? Do they always remain loyal and friendly to the human body, or can they be converted into pathogens? What are their enemies? What are their food preferences? And so on. You have, I didn't determine the number of lines or words that you write, but of course, you should take care of your punctuation, because too many punctuation or spelling mistakes will make you lose marks. And there should be some creativity in your dialogue, because the dialogue and the drawing are a good opportunity for you to get extra credit or a bonus on the test. I wish you all the best of luck, inshallah, and I'll be there at school, or at least I'll be over the phone to answer your questions. So please don't hesitate or be reluctant to ask questions, because whether I am at school in the admin room or I am at home, I'll be answering your questions over the phone, because you will be taking your test in the assembly room. But please don't hesitate to ask questions if you have any, or if you really don't understand what the question wants to say. I wish you all, again, good luck with the test, and I'll be seeing you the week after the test, inshallah. Thank you. Bye-bye.